So I'll start by introducing myself and just talk a little bit about what we're doing tonight. And then I'm going to hand the reins over to our guest speaker, Jess Cumming, which is awesome to have you here, Jess. So I'll introduce myself. My name's Day Hagel. I'm the director of Mental Health Wilderness First Aid. And some of you folks know me and have taken courses already or signed up for courses, which is awesome. And some of you may not. But we run programs in mental health first aid that are oriented specifically to folks who live, work, or play out in wilderness or remote areas. And so we do a lot of work with outdoor educators and outdoor guides, which is mostly my own personal background. We also work with a lot of search and rescue groups. We do silviculture and other remote kind of industry folks, and basically, anyone who lives, works, or plays out in remote areas. And so in addition to running the courses, we also host guest speaker events, and that's to help get a little bit more kind of expertise that I don't necessarily have, and also to create a bit of a culture of learning and a community of learning as well. So it's lovely to see some of you back and some of you here for the first time. And I'll start by introducing our guest speaker, and then I think I'll just hand it over to you, Jess. I should say as well, so Jess is probably just going to kind of keep trucking on through her presentation here, and then we'll do the bulk of questions toward the end. If you do have something that you want to kind of interrupt with or clarify something, that kind of thing, then you can either drop a note in the chat, or you can, stick your hand up or use the little raised hand function on Zoom. If that's helpful to you, and just ask your question as we go, that's fine as well. Jess probably is not going to be able to see the chat as she's presenting. So Sean and myself are here. You can see the other two kind of co-hosts in the list of participants. And so we will be keeping an eye on the chat. We can respond in the chat as we go. We're also here, especially Sean, to help with any kind of tech issues, right? If someone gets kicked out or whatever, or needs any help behind the scenes, you can definitely send one of us a PM. Sean, do you want to introduce yourself real quick?
Interrupt me if there's something in the chat that you want me to respond to. Feel free to interrupt me.
Yeah, definitely. Yeah, and Sean and I will draw your attention, Jess, to anything that you may have missed as well. But so Sean is here as well, and Sean does admin for Mental Health Wilderness First Aid, and he's also a meditation and mindfulness coach and instructor, which is pretty great. Do you want to introduce yourself or say anything else about yourself there, Sean, or where are you?
Yeah, so I am on the land of Coast Salish nations, specifically the Katzie Nation, the unceded and traditional land, and otherwise known as Maple Ridge, which is also probably not much context for most people. So it's about an hour east of Vancouver, British Columbia. Mm-hmm. So yeah, that's where I am. And yeah, like Day said, I'm a mindfulness and meditation teacher and coach, and I create content for a few of the world's largest meditation apps like Aura and Insight Timer. And I also just do some private coaching and teaching as well.
Very cool. Yeah, thanks for being here, Sean. I'm on Salt Spring Island, which is about an hour by ferry west of Vancouver, so opposite sides of Vancouver. And so I'll just introduce Jess here. So I invited Jess on. I'm very excited to have Jess here. It's been a while. I invited Jess on because Jess and I completed our master's in Counselling Psychology together at the University of Victoria in 2018. I think Jess actually graduated a little earlier than I did. But so Jess always impressed upon me her compassionate lens in working with people who are struggling, but also specifically with her clinical organization and her capacity. And so ever since then, Jess has continued to be an asset to us as I've grown my own business with Mental Health Wilderness First Aid. She's a clinical counselor, but she has helped us in a number of different ways. She completed a thorough copy edit of my citations in the first edition of the Mental Health Wilderness First Aid Manual, which is wonderful because as much as I enjoyed writing the manual, I also struggle with putting things in APA format and doing my citations. Jess has always had a little more of a lens on that than myself. So Jess Cumming is a Canadian certified counselor with the Canadian Counselling and Psychotherapy Association. She works as a therapist at Thrive Downtown Counselling in Vancouver BC. As I said, she graduated with her master's in counseling psychology from the University of Victoria, and her areas of interest include disordered eating, trauma, and incorporating spirituality into therapy. Utilizing models such as emotion-focused therapy and internal family systems, she aims to provide safe and supportive environment for clients to explore and deepen their relationship with their authentic selves. So we are excited to welcome Jess here tonight to share with us some of her expertise and background in supporting folks who may have disordered eating out in backcountry situations. So this is a topic that we have not had as part of the mental health wilderness first aid curriculum before. We cover a lot of other kind of mental health topics, but this is a topic that's probably most frequently requested by our students that we haven't covered so far. So I'm very excited to have Jess here. And as always, the views expressed by the guest speakers are their own and may or may not reflect the views of mental health wilderness first aid. So Jess, would you like to introduce yourself anymore? Anything I missed? And then maybe I'll just hand it over to you.
You did a really good job. So hi, everyone. Welcome. It's great to see so many faces here. And like Day said, I do have a certain level of knowledge around this topic, but I know we have a lot of other expertise in the room as well in your own fields around wilderness guiding and education. So just want to preface this by saying, I know that some of the suggestions that I make in this presentation for supporting people may or may not work in different settings that you guys are working in. So please just take whatever is useful to you and leave the rest. So I'll be going fairly quickly through the slides that I have today because there's a lot for us to cover, but I'm happy to provide copies of these slides after the presentation, as well as my email if anybody has any follow-up questions after we're done. Okay, so I'm just going to take a minute here and get my slides set up. Just reorganizing my Zoom a bit here so I can see everybody's faces. There we go. All right. Okay, so the first thing I'd like to start with is a land acknowledgement. So I'm presenting today from the unceded ancestral homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. I'm guessing in a group like this, everybody is aware of whatever Indigenous nations territory they are coming to us from. So I'll just ask that everybody takes a moment to reflect on our connection to this land and some gratitude for the Indigenous stewards of that land. So I'm going to kick things off here with a few different case presentations. And so these are just some scenarios that you can have in the back of your mind as we move through the presentation. We're going to discuss them in detail not in super detail, but we'll discuss a little bit more at the end. But this is just to give you a bit of a framework of some things that you could run into in the types of settings you guys are working in. So the first one that we have here is Peyton. So Peyton is on your team in a remote work camp. You notice that Peyton often complains about having stomachache after meals and seems to spend long periods of time in the outhouse or excuse herself to the woods alone right after mealtimes. One day she admits to you that she's been feeling guilty about overeating and has been making herself throw up. Next up, we have Gunnar. So Gunnar is an adult in the field on a backpacking trip. He brought a scale with him and weighs everything that he eats. He talks about calories a lot and needing to maintain the same caloric intake as he had at home, even though the hike is moderately strenuous. He says that hiking is the best way I could think of to lose weight. He has been tired and even a little bit faint on the trail. Orly is a youth in the field with you. She has a high number of food preferences, which she is quite vocal about and refuses to eat what she calls bad foods, which includes anything with fat or carbohydrates in it. She also refuses to eat snacks. Your trip is not too strenuous, but Orly has been having trouble staying warm, and other youth in the group are aware of what Orly is saying. So these are just some examples of how this can show up. And so, like I said, we'll go over this a little bit more towards the end of the presentation. But hopefully, I will be giving you enough information that you'll have some idea by that point of what might be helpful for these people. Okay, so on this slide, we have the continuum of eating disorder behaviors. So on the one hand, you have what would be considered sort of normal or regular eating, people listening to their body in order to figure out what they're going to eat and how much they're going to eat, not experiencing any intense emotion around it, being able to incorporate variety and balance, avoiding any rules around food or fears of specific food. Really, it's the idea, it's this being able to be flexible, being able to be spontaneous, and being able to give your body what it needs. On the opposite end, in the middle, we have disordered eating. So that's kind of those in-between people who they're probably quite influenced by diet culture, by trying to control their weight or lose weight or maintain a certain size. You may see these people experiencing guilt around certain types of food, maybe not eating so much according to their internal cues, but more based on their ideas around what is the sort of a correct amount to eat. There may be a lot of comparison with other people, counting calories, and are having food rules or being preoccupied by food quite a bit. And then on the more extreme end, you have what would be actually diagnosed as an eating disorder. So I'm not going to go into detail today about the actual eating disorder diagnoses. If you have questions about that, you can let me know either at the end of the presentation or by email later. But I think for the purposes of this group, really, like, an eating disorder is that sort of consistently being influenced by food restriction, focus a lot on weight loss, really intense feelings around eating. There's often a lot of secrecy, trying to hide things, whether that's like hiding food or hiding the fact that they're not eating, wearing big clothes to hide weight loss, things like that. And the food rules in an eating disorder can be very rigid, very restrictive. And when we ask people who are diagnosed with eating disorders how much they're thinking about food, you'll often get answers somewhere between 80% and 100% of their day. So it really does become kind of the sole focus of that person's life. And then we also get these compensatory behaviors, such as purging, over-exercising. Binging is also a feature of eating disorders in a lot of cases. All right, so these are just a few definitions that may be helpful to have in the back of your head as we go through the presentation. So weight stigma refers to treating people poorly based on their size, typically people who are on the larger end of the weight spectrum. Fat phobia is the fear of fatness. So that includes the fear of becoming fat oneself, but also in other people and can result in those weight stigmatizing behaviors. Diet culture refers to the environment and cultural messaging around food and bodies in our society, which leads to this rigid set of beliefs around thinness being equal to health, worth, and overall wellness. And then there has been sort of a counter movement over the last, I think it's started in the 80s or 90s, the health at every size movement. So this was pioneered by author Lindo Bacon and has become more widespread since they published a book in 2008 by that same name. And this movement advocates for the respectful and equal treatment in healthcare of people of all shapes and sizes. So one of the things that's really important to recognize is that eating disorders happen across the spectrum of gender, across the spectrum of culture, race, ethnicity, sexuality, and every other aspect of intersectionality. So these are some examples of people working in the eating disorder space from different marginalized identities. So on the left, we have Gloria Lucas, who is a Latina harm reduction eating disorder practitioner. In the middle there, we have Erin Flores, who is a male eating disorder dietitian. There's fat activists, Aubrey Gordon and Virgie Tovar are in there. Sonia Renee Taylor and Sabrina Strings are authors who have done some excellent work on the intersection between eating disorders and racism. And then, as I mentioned on the previous slide, we have Linda Bacon, as well as their book there. So if you have an older copy of the book, it may say Linda Bacon. Linda Bacon has since come out as a non-binary person. And yeah, so there are a lot of stereotypes still kicking around about who gets eating disorders. It's historically been viewed as something that only affects thin white women. And when we look at the numbers, this is simply not the case. But there is still that kind of popular view out there that we are trying to work against. Okay, so I'm just going to go through some of the functions that an eating disorder performs in a person's life. So the reasons that someone might develop an eating disorder. So one is making things seem more orderly and predictable when life feels chaotic or out of control. It can help with avoiding and regulating emotions that feel too painful to be experienced directly, and help to create a sense of identity. And often it will start as a diet or an attempt to lose a small amount of weight that then kind of spirals out of control. And for many people who experience eating disorders, they find that it is actually comforting in a way and can actually be experienced as a friendly companion. So there's a lot of factors that go into the development of an eating disorder. I'm not going to go through all of them, but broadly speaking, these can be categorized into genetic factors. So there is thought to be some level of heritable component to an eating disorder, psychological factors, so certain personality traits or life experiences can contribute, as well as social factors. So whether that's things in the family of origin growing up or within peer groups as people get older. Okay, so I imagine that this is something that'll be relevant to a lot of you guys, things to look out for. If you're taking groups out into the wilderness, you might want to know what are some of the signs you might notice if someone is struggling with an eating disorder. So these are a few of the things that you might notice or be paying attention to if you suspect that somebody in your group may have an eating disorder. None of these things by themselves can ever guarantee that someone is struggling with their eating. For example, being preoccupied with food and calories can be quite typical during adolescent development. But when you start to see groups or clusters of these signs and behaviors, that is an indication that you might want to be concerned about someone. So things like being really preoccupied with weight, food, and shape, talking a lot about food, excessive exercise, especially alone or in secret. So if you're out on a hiking trip and you notice that someone is getting up to run at 7 o'clock in the morning before you start out, or that they're doing sit-ups alone in their tent, that's definitely a big red flag. I put an asterisk next to low body weight because while this is the sign that we most commonly associate with eating disorders, it's not necessarily present in all cases. If somebody starts out in a much larger body, they may appear to be within a quote unquote healthy weight range and yet still have lost a dangerous amount of weight in a short time. There are also people who can exhibit all of these other signs and symptoms of eating disorders who never lose a significant amount of weight at all. So it's very important not to discount any of these other concerning behaviors we might see just because someone does not appear to be underweight. So some other things to look at would be hoarding or hiding food, not wanting or being comfortable eating in front of others, general withdrawal or isolation, extreme fatigue. Scars or scabs on the knuckles can indicate that somebody has been purging by vomiting. So that happens when the teeth bump up against the knuckles when someone's putting their fingers down their throat. When somebody is at a low weight, they may actually start to grow fine hair all over their skin, particularly on the stomach and on the arms. And then the hair on the head may be thinning or falling out. So there's a couple of screening tools that are out there that you can use. This first one is called the SCOFF questionnaire, and it's just a series of 5 questions. And again, like this one is to be taken with a grain of salt. There is some stuff around weight loss in there. And as I mentioned, that's not necessarily present. But if you're seeing that the person is checking all these boxes, then yeah, that's an indication that you want to be concerned about that person. So the S stands for sick. So making oneself sick because they feel too full. The C stands for control, for loss of control over how much you're eating. I believe this is a British instrument because they talk about losing more than 1 stone as the O. So that would be 14 pounds over a period of 3 months. First F is for believing yourself to be fat when other people say you're too thin. Again, this is kind of an outdated question to be basing it on. This last one is a good one, though. Food dominating your life is a big indication of at least disordered eating, if not an eating disorder. There is another screening tool that you can use. This one does require access to the internet, so I know that may not necessarily work for everybody in a wilderness setting. But if you do have access to the internet, this can provide an indication of whether further evaluation for an eating disorder is warranted. So none of these tools are going to tell you 100% for sure one way or the other. Like, yes, this person is struggling with an eating disorder, or no, they are not. However, it can be a good indication of when to encourage somebody to seek further medical attention. Just a note about the language on this screening tool. So if there's any possibility that the person does have an eating disorder, the result that you will get is you may be at risk. And this is like, it will be that sort of tentative language, even if somebody is displaying quite severe symptoms. So I tested this out when I was doing research for the presentation, and I sort of checked off every single box of the most severe symptoms that you could have. And it still said you may be at risk, where I was looking at that and being like, oh yeah, get that person to a hospital. So just keeping that in mind if you're going to be using this one.
Can I ask you a quick question, Jess?
Absolutely.
Yeah, a couple slides earlier, you said that one of the signs could be something like the growth of that fine downy hair, or maybe hair falling out. Is that what I'm thinking? Just like a side effect of a nutritional deficit, or can you comment on that?
Yes, that's that would be from well, okay. So the hair loss, definitely from lack of nutrients. The lanugo, which is the fine hair that grows on the body, that's a consequence of low weight. And so it's actually like the hair is growing in order to keep the person warm, because people struggle to keep warm when they're at a low body weight. Although that said, you can get problems with temperature regulation for somebody who's at a higher weight if there has been significant restriction. So it doesn't necessarily have to be that they're at a low body weight, just that either they've lost weight from where they were at before, or they're just significantly nutritionally depleted. And that can happen quite quickly. Okay, so these are the scary ones. So if you're seeing any of these signs, this is an indication that you want to get this person to a doctor as soon as is reasonably possible. So dizziness, fainting, confusion, seizures, and difficulty speaking can all be signs of severe hypoglycemia or low blood sugar. So the first thing to do if you're seeing these things is to get that person to eat something right away. But even if they have eaten, they should still be evaluated by a doctor, especially if they've fainted or had a seizure. So blood in the vomit can be an indication of a tear in the esophagus or the stomach lining. Chest pain is a tricky one because it can be a result of anxiety, which is very often present in people with eating disorders, but it can also be a sign of heart problems, which is a possible complication of an eating disorder. So you always want to have that person get checked out just to be sure. And then numbness, muscle cramps, nausea, and vomiting and confusion. All of those can suggest an electrolyte imbalance, which can possibly lead to heart failure. So in that case, you want to get somebody, at the very least, something to drink with salt in it, preferably something with added electrolytes. If you have like electrolyte powders that you carry with you, or probably something like Gatorade would be heavy to carry around, but always a good idea to have some sort of electrolyte supplement on hand. Okay, so now we're going to get into the ways that you can practically support someone with an eating disorder during an expedition. So some of you will probably already be familiar with this. This is the Stages of Change model, which was proposed by authors Prochaska and Di Clemente in 1984. And so this is to describe where someone is at in any process of change. So the strategies that you're going to use to help someone with an eating disorder will vary significantly depending on where they fall on this continuum. So the pre-contemplation stage occurs before someone has an awareness that they have a problem that requires changing. Once they do recognize this, they go into contemplation. So that's recognizing that there is a problem and the consideration of doing something about it. Preparation is where someone starts to take steps to get things in order to support the eventual change. And action stage is where the change is actually implemented. So from there, it kind of splits off, and the person will either enter maintenance, where the change is solidified over time, or relapse, where they return to an earlier state in the model. So it's important to mention that these stages are not this linear in real life. So you may have somebody jumping from one stage to 2 stages ahead. If that happens, often they will go backwards and have to complete the stages or the tasks that weren't completed in those earlier stages at a later time. People go back and forth between stages. Sometimes people will have features of one stage and also features of the next stage and kind of straddle the two for a while. And, somebody may spend years in pre-contemplation or years in contemplation and then maybe progress quite quickly through the rest of the stages. It really just depends on the individual. But determining what stage a person is at with their eating disorder can really help in deciding what type of help and support you're going to be providing. So, for example, if somebody's in pre-contemplation, support might consist of asking gentle probing questions and expressing concern calmly and compassionately to raise that person's awareness that something might be wrong. If they're in the action stage, on the other hand, so this might look like someone who's been in treatment for some time and really already has a handle on their eating disorder, but is maybe struggling with something specific, then they might need more active support. So that can look like providing support during and after meals. And we'll go through how to do that next. So meal support is emotional support that's provided while someone is eating, as well as before and after. And the goals of this are to help them to normalize their eating, to facilitate weight gain or weight maintenance, depending on whether dangerously low weight is a feature of their eating disorder. To really help them to have some success with completing a meal so that they can build up their confidence in being able to do this themselves in the future, and to limit the use of rituals and fears around food. So this is the type of eating that is used in most treatment programs, both inpatient and what's recommended in outpatient treatment. So if somebody has been in eating disorder treatment, this is what they'll be familiar with. So this is the rule of threes, having 3 meals a day, 3 snacks a day, and not eating more than 3 hours apart. I've also heard a 4th 3 used, which is at least 3 food groups per meal. Only 2 is necessary if it's just a snack. So some people will look at this and say that it sounds like a lot of food, which for someone not recovering from an eating disorder, it can be. But when somebody is trying to build back up their nutritional status after being depleted for some time, this is what's required for that rehabilitation. And it's also important to consider that if the trip that you're on involves any kind of strenuous activity like hiking, meals will need to be bigger as a result of that. So this is the temporary measure. It's creating some structure in order to help the person to get things going with nutritional rehabilitation until they're able to do this more on their own. So mealtimes are really challenging for somebody with an eating disorder, and you may see a lot of these behaviors which can appear kind of extreme, but this is not uncommon for somebody who is struggling with an eating disorder. So you may see them get really angry at the dinner table. You may see them experiencing high levels of anxiety. They may disagree with what they're expected to eat. They may refuse to complete their meal. Physical discomfort is really common, especially if they're early in the refeeding process. And this, we do see like people complaining of physical discomfort as a way to get out of eating, but it's also a real phenomenon that will happen when the stomach has gotten used to not having a lot of food in it. Same with not being hungry. So you may hear someone say that they're not hungry when actually they're starving, but they may also just be experiencing a lack of appetite because those hunger signals will turn off after they've been ignored for some time, because the body is just redirecting those functions to other things to conserve energy. As I mentioned before, it's very common for people with eating disorders to feel uncomfortable eating in front of other people. So if somebody's not wanting to eat with the group, that can be that's a normal thing to expect. A lot of people will have fear foods if they have an eating disorder, and this list can be quite extensive. Anything with sugar, anything with carbs, anything with oils. So, depending on the person, they may be very, very, very limited in what they'll agree to eat. Talking about food, about calories, about weight at the table, quite common as well. And then you get different types of rituals around food. And so there's different purposes of this. Partially, it's around kind of slowing it down because they allow themselves to eat so infrequently that they want to savor what they do eat. But it can also be a way of making it look like they're eating more than they are. So things like cutting foods up into small pieces, hiding food, eating really slow, or dumping large amounts of condiments. That can also be because taste can be altered, and so they might not be able to taste sort of more normally flavored foods. And then you might see people moving around a lot during meals, trying to burn off energy as they're eating. So it can be hard to know what to say to somebody who's experiencing those high levels of distress around food. So I really like this framework of emotion coaching, which comes from LaFrance and Dulhanty's emotion-focused family therapy. This is an approach that is gaining a lot of traction in the mental health space for those caring for someone who is recovering from any type of mental health condition. But in the beginning, it actually was originally developed specifically for eating disorders. So it works really well in this context. So this version of emotion coaching has been simplified from an earlier 5-step model, condensing it down to the 2 core principles that are most important for providing emotional support to someone with an eating disorder. So the first step is validation. And the order of these steps is really crucial, because when somebody's in that heightened state of anxiety or intense emotion, we can't reasonably expect them to be able to use logic, to use their left brain where those reasoning skills live. So in EFFT, they talk about this idea that emotion is on the top floor of a building and logic is down on the bottom floor. And validation is the elevator that takes the person down from that top floor of emotion down to the bottom floor so they can engage in a more rational discussion and maybe some problem solving. So validation is simply about adopting and communicating understanding of someone else's perspective, even if that perspective significantly and dramatically differs from your own viewpoint. So this is really helpful with working with eating disorders, because some of the things that provoke intense emotion might appear completely illogical or strange to someone who does not have an eating disorder. So as an example, someone with an eating disorder might say, I'm terrified that if I put butter on my toast, I'm going to instantly gain 10 pounds. And like that might be them exaggerating a little bit, or they might really believe that or believe something along those lines. So this is where really focusing on the feeling there, the fear, is really important, rather than getting into the details of what that person is talking about. So, wow, I can see that you're so scared around completing this meal. And then you can move into, like, once they've calmed down, you can move into the second step, which is practical support. So, okay, what can we do to help you to get through this? What can we focus your mind on in order to make this easier to complete this meal? So this is where you have things like problem solving, creating a safety and support plan, creating a plan ahead of time for meal times, sitting with someone during meals, holding their hand during the meals, talking about what types of things would be helpful for them to hear during the meal, ways that they'd like to be distracted, other topics that they like to focus on. But it's really important that first we've done that step of really seeing that place of emotion that person is at. So you can find a ton more information and guidance on emotion coaching on the Mental Health Foundation's website, and I've put that on the resources slide at the end of the presentation. So something else that you can do is to serve as a healthy role model. And in the context of eating disorders, what that looks like is just avoiding all talk about people's weight. It's necessary, it's often boring, and there's so many other things that we can focus on. Same thing with comments about your own body, your own plans to diet, other people's appearances. If you're in a group context, really making sure that there is no making fun of people around their weight or appearance. And that includes like people that are not present. Like it's obvious that we don't want people making fun of each other's weight. I think we all kind of intuitively know that, but it can come in really insidious ways, especially if there's, someone in the media that's sort of generally disliked. And oftentimes, like a really easy way to target that is making fun of their weight. So looking out for little things like that. Expressing appreciation and validation of other qualities outside of looks and appearance. And then really like modeling your own enjoyment of food and being able to balance meals, having a variety of foods, and avoiding any labeling of foods as good or bad. So something to really watch out for in a group, especially if you're working with young people, is the sort of contagion effect where eating disorder behaviors, unfortunately, can spread and influence one another. Teenagers are impressionable. Adults can be impressionable too, but this is especially a concern for those who are working with youth. And so really keeping an eye on everyone else in the group as well. It can be really upsetting and stressful to witness somebody that's going through this. People may feel powerless to help, especially if it's someone that they're friends with. So really not just focusing on supporting the person who does have the eating disorder, but also keeping an eye on the rest of the group as well. Sort of checking in to see, is there anyone who seems to be particularly affected, and what can you do to support that person, really checking in on them, seeing how they may be impacted by the situation. Another thing you may find is that if other group members are aware of the situation, which they typically will be, like kids are smart, they will pick up on this stuff. And they may want to help out. So a way that they can do this that's sort of age appropriate is by just providing distraction and conversation at meal times, rather than kind of getting into that like helper or caretaker role. Okay. So I'm going to spend some time on this model of intuitive eating, because this is something you definitely will see in eating disorder treatment spaces. So if you have someone in your group who is further along in their eating disorder journey, maybe has been through some treatment, is further along in the recovery process, it may be appropriate to encourage this type of eating. This is typically what's seen as the gold standard for where we want people to be at by the end of their eating disorder recovery. And if they have been in any type of treatment program, this is something that will probably already be familiar to them. So these are the 10 principles of intuitive eating. So this is outlined by Evelyn Trivoli and Elise Resch in their book by that same title. It's now in its 4th edition. And if you're interested, you can read more about this approach in that book. But if you do that, I would recommend that you get the latest edition, because a lot of things have changed since the original was published. You can also find an updated version on the website that I've listed at the bottom of this slide. Like I said, it's good to know the basics of this one because it is common in eating disorder treatment programs, and most dietitians in the eating disorder space, this is the approach that they will use. It's also just a really good paradigm for most of us to be aware of, even for ourselves. We can all be susceptible to the subtle influences of diet culture that we're surrounded by in this Western world. So these principles are really good ones to be aware of, and maybe to think about, like, are there ways that I can incorporate this more in my own life? So the first one we have here is to reject the diet mentality. So that's referring to those diet culture rules, those sneaky little ways that we're all influenced by cultural messaging around food, weight, and shape. The second one is to honor your hunger. A lot of us do kind of go around eating based on sort of when and how much we think we should, and not really kind of tuning in, listening to those internal cues that let us know, am I hungry? Am I full? Do I need to eat more? The third one is making peace with food. So this really refers to those kind of rules and restrictions around, all foods of this type is bad. I can't eat any sugar ever. So really just kind of, are there ways that you can make more space that all foods can be acceptable and incorporated into a balanced and healthy diet without fear, with obvious exceptions such as allergies and things like that. The fourth one is to challenge the food police. So this may refer to, external people that might be commenting on what someone is eating or their weight. It can also refer to those internalized food police that we kind of create through a lifetime of being exposed to these kinds of messages around food and eating. Number 5 is to discover the satisfaction factor. So that really refers to like reconnecting to those ways that food can be pleasurable and enjoyable. So thinking about foods that you really love and taking time to savor that when you're kind of by yourself with time to really slow down and enjoy a meal. Or it can be those social eating experiences, holidays, restaurant meals with people that we love. So just kind of reconnecting and remembering that that food has been at the center of our celebrations throughout the history of humanity, and that's for a reason. It's enjoyable, it's pleasurable, and so I think we can often lose sight of that. Number 6 is to feel your fullness. So learning to recognize those signals that let you know that I've had enough to eat. And this one, I'll put a little asterisk around. So like as we go up, like this really does go in order when somebody is recovering from an eating disorder. Like there's a reason that rejecting diet mentality and honoring hunger, those are like the first ones that we go to. Once we get into this like later half of the steps, these are things that are going to be kind of more advanced. So often someone with an eating disorder will want to jump straight to step 6. Okay, I'm going to do intuitive eating, but I'm really going to focus on when do I stop and like feeling that first sign of fullness and okay, I'm done. And it's also one that if somebody is in recovery from a restrictive eating disorder, early on, those fullness cues are not going to be reliable. So you're going to get people feeling full too early because their stomach's just not used to handling that amount of food as it normally would be. So that's something to pay attention to as well and kind of leave that for a later stage if somebody's really early on. Number 7, coping with emotions with kindness. So we often hear a lot about emotional eating. A lot of what we think of as emotional eating is actually just a kind of pendulum swing response to restriction. But you do get those cases where people have sort of not learned other skills for recognizing and working with their emotions. So this is where therapy is great. This is where emotion coaching is great. Bringing in those other tools that somebody may already have or may need to develop in order to manage emotions. Number 8 is respecting one's body. So, that can be things like making sure that you're getting rest, making sure that you are getting enough sleep, making sure that you're drinking enough water. So really honoring the body in those ways. Number 9 is, again, a bit of an advanced one. So exercise. And when we say exercise in this context, it's really like what we refer to as joyful movement. So finding ways of moving the body that really feel good for movement's sake, not as a way to control or shape one's appearance. And then the final one is bringing in some of those gentle nutrition principles. So being able to incorporate variety and balance and eating from a wide range of foods, maybe limiting things that you notice make the body feel not so great. But again, like really making sure that that's not coming from a restrictive place or deprivation. This is just a little bit about what eating disorder treatment can look like. So if you've got
Jess,
yeah.
Do you have time for a question?
Absolutely.
I don't want to interrupt your flow because it's so great, but can you go back to the intuitive eating slide for just a moment?
Absolutely.
I just love this this slide and this tool, and I think it can be such a powerful thing, for everyone. So I love that you included it. I just was kind of putting 2 and 2 together as you were talking, and you were talking about the idea of feeling your fullness and how that's there's a reason that's number 6, right? You don't start there if someone is coming from having disordered eating or an eating disorder or is in those kind of earlier stages of recovery. And I was just reflecting also on one of the things that you said earlier is important for if somebody is in the early stages of recovery is that they eat frequently. You said something like 3 meals spaced, a certain length of time apart, but also including the snacks in there. And I just connected that those 2 are probably connected, right? Because the fullness cues might be off if somebody, I don't know if it's real that your stomach shrinks, right? But that they might feel full after only eating a tiny bit. And so that might be one of the reasons why they're prompting you to, have a snack in just a couple of hours later and make sure that you eat frequently.
Yeah, in a sense, yes. Although, like, if you look at the meal plan of somebody who's early on in their eating disorder recovery, and not like they do build up to this, but like it's like 3,000-4,000 calories. So you're like looking at like basically double what somebody not struggling with an eating disorder would be eating in an average day. So like, yes, they're eating frequently, but they're also eating quite a bit. Mm-hmm. And that is really like to sort of rebuild those nutritional building blocks that have been, somebody's been restricting their eating for a long time. It requires a lot of energy to get all of the systems of the body back functioning the way that they're supposed to.
Gotcha. So a lot of it's like just rebuilding those physical building blocks, like you said. And I imagine some of it's also maybe around trying to reshape their own relationship with food psychologically. Is it something like that?
Yeah, absolutely. Like getting used to that idea of eating regularly, eating on a schedule. Some people will stay in that, so this intuitive eating is the end point. But early on in eating disorder recovery, which I haven't gone into this, they do what's called mechanical eating. And so that's that structured 3 meals a day, 3 snacks, and just like really like clockwork on timer. Because people with eating disorders often will also love rules. So it's a system that kind of works with where they're at. And yeah, so that's really thinking like food is medicine is another sort of way that that some eating disorder dietitians will talk about that, really getting the basics back. Somebody is in that recovery phase.
Yeah. Thanks so much for expanding on that. I just think this is such a great tool, and I was introduced to it myself fairly recently, and it just seems so mindful and respectful and like such
absolutely. Yeah. And it's really evolved over the years as well to really kind of keep up with current thinking around this stuff. So it's a super helpful model that I've implemented a lot in my own works. Awesome. Okay. So if you come across somebody who's very early on in their eating disorder journey, they may have a lot of fear around seeking help. Like, often like being away from home is often the place that an eating disorder is discovered, because it's not normal that we kind of are with the same people day in and day out, in the kind of context that you guys would be in, where anybody would really be paying attention to someone's eating behavior. Like when you're in your day-to-day routine, it's really easy to hide. Oh, I ate at a friend's house, or I'm gonna grab something when I get home. I'm too busy right now. And so this is something you guys might be encountering. And so these people might not know much about what to expect if they do tell someone, if they do really seek out those resources. So it can be helpful to know a little bit about what supports look like. So most programs that are, or most places around the province, I assume everyone's somewhere in BC. So there are government-funded multidisciplinary eating disorder treatment programs really across the country. And most of those teams will include a number of different professionals, because eating disorders are so complex and involve the body, the mind, and everything in between. So you'll probably see at least a doctor, a counselor, and a dietitian on someone's treatment team, and sometimes also other professionals. So that can be things like recreational therapists, occupational therapists, art therapists, nurses, and mental health support workers, who will all have different roles in helping people. Typically, it's quite typical that adolescent programs are individual and adult programs are group-based, because of funding purposes and just the feasibility of providing that level of individualized support for the larger adult population. And you also have different levels of treatment. So that would include inpatient treatment, residential treatment, and outpatient treatment. So the difference between inpatient and residential is inpatient is in a hospital setting, whereas residential, they would typically be living in like a house or some kind of group living situation. Quickly, any questions around treatment and what that looks like? Okay, cool. Okay, so if you've been through the mental health wilderness first aid program, you'll be familiar with this concept of having a safety and support plan. So these are just some things to keep in mind if you're creating such a plan for somebody with an eating disorder specifically. So when we're supporting people with their mental health, we're often taught to guide people towards identifying what they feel in their bodies. So this is equally important for people with eating disorders, but they're a lot more likely to have a difficult time recognizing their internal experience compared to somebody without an eating disorder. So when you're asking about this, it can be helpful to provide examples or suggestions as to what they may be experiencing. And then if talking about the body is too distressing, don't push them too much to do so. So while distraction is not necessarily a good long-term coping solution, it can be a very helpful stepping stone while somebody's learning to manage their eating disorder symptoms and understand underlying emotions. What else here? So it may be unrealistic to expect that someone with an eating disorder is able to recognize where their thinking has become distorted or unrealistic. And this is because starvation impacts the brain. So it's not that the person, we don't trust the person to be, competent or logical, but when the brain is in a depleted state, it's kind of an exaggerated or heightened version of what I was talking about earlier of the effects of emotion on the brain, where it's like you're just so easily flooded, you're just so easily overwhelmed that it's just not fair to expect the person to be able to reason. So that's something to keep in mind as well. after a meal is usually a very stressful time. And so that's why we suggest an hour of post-meal support where possible. So this is a time where people will experience high anxiety, strong guilt about eating what they consider to be too much, feelings of shame, and also that physical discomfort. So feeling too full, feeling bloated. And that's where you often see that urge to get rid of the food or calories through purging or through exercise. So the time to work on a safety and support plan with someone with an eating disorder is as far away from mealtime as possible. Now, when someone's eating 6 times a day, that can be challenging to find that window of opportunity. But I would say if it can be at least an hour outside of mealtime, that would be useful. And that's the time where you can kind of review like what would be helpful during meal times, talk about what will happen if you see things like those food rituals happening at the table, and also agreeing on a time limit for meals. So if someone with an eating disorder had their way, they would probably sit at the table for like 2 to 3 hours. So you might want to agree on a time limit, something like 30 to 45 minutes for a meal, 15 to 20 minutes for a snack. Otherwise, your plan for the rest of the day may get a little bit derailed. So, the other piece around that post-meal support is it's often a good idea to restrict them from using the bathroom. Again, I don't know how doable that is if you're in a like peeing in the woods situation or something like that, but where possible, or if they agree to it, possibly having somebody go with them and kind of stand with their back turned, because you would hear it if somebody is purging. And the other purpose of that is, or the other thing that you might want to consider during that time is limiting standing and exercise. Again, where possible, if you're on a hiking trip and you need to get back on the trail right away, obviously that's not necessarily going to be feasible, but just kind of use whatever you can of these suggestions. These are a couple of resources that you may include in a safety and support plan for after when the person is going home. Kelty Mental Health is a great one-stop shop for information and resources for professionals, families, and the person with the eating disorders themselves. This one is primarily youth-focused. The Looking Glass Foundation is best known for their residential treatment program, but they also run online peer support, low-cost counseling programs, a volunteer mentorship program, and they also maintain a directory of therapists who specialize in eating disorders. Again, this is primarily youth-focused, but some of these programs and resources are available to older people as well. And the therapist directory, lots of those counselors will see people at any age. Next, so we have the National Eating Disorders Information Center, which has information and resources for getting help. And then they also run a national helpline, which is that number that you see there on the screen. There's also an online chat version of that, which is available at the website as well. Okay. So let's circle back to those case studies from the beginning of the presentation. I'm not going to read through them again, but they're up on the screen if you want to refresh your memory. And so I figure we can just have a little bit of a discussion here around how you might broach a conversation with each of these people about your concerns. Something else to think about is like what you might include in their safety and support plan, and things that might let you know that they might need to go and seek medical attention. So I'll open up to either suggestions, things that you like, kind of your best guess of how you can kind of pick one of the case scenarios and say how you might handle that, or any questions that you might have about each of these scenarios.
I have so many questions and little things that I've written down as points of interest, but I would love to hear if anyone else wants to voice any questions or ideas first.
I have a question. I'm thinking about the theme of like risk management with working with students or just humans with eating disorders in the field. And I'm looking specifically at the one with Gunner, saying that they have been tired and faint on the trail. I know eating disorders can have a lot of physical impacts on how people are able to show up to a course, and like specifically in like really physically demanding environments. I'm curious what your take is on like how to know when to evac someone, or think more about like concrete things to manage that risk of like someone being like compromised or like physically unable to do the challenges.
Yeah, I would say like to be on the safe side, like if you're seeing any of the things that were on that slide around medical risks. So like, if somebody's a little lightheaded, a little dizzy, you can probably just, if they will agree to eat something, give them a snack, give them some time and sort of allow them to continue on. But if somebody's actually fainted or lost consciousness, you want to get them out of there. And similarly with any of the pieces around electrolyte imbalances, that's one that like it can be corrected if they supplement with electrolytes. But if those symptoms are persisting, because like electrolytes can get depleted really quick if somebody's not eating enough, or especially if they're purging, that really messes with the electrolytes. So like if they have muscle cramps that aren't resolving, or, again, like passing out can be an indication of that one as well. So like any of those ones, if it's not resolving if they've supplemented with electrolytes, definitely you're going to want to watch out for that. And then if they've been vomiting and they report to you that there was blood in the vomit, then absolutely they need to seek medical attention. Does that help?
Yeah, that's helpful. Thank you.
I think one thing I was wondering about, which kind of connects maybe to Joe's question, is something like, so how would you suggest maybe opening a conversation with these folks? And I give the example, so in the course, in the upgrade version of the course, where we talk about what you might think of as more serious things, that we talk about people who are thinking of suicide, for instance, or who might be thinking of suicide, and we're wondering if they might be thinking of suicide. And we talk about the importance and the power of, taking a deep breath, finding a nice time and place, and maybe they're away from the group and you have a chance for a one-on-one chat, but you ask a direct question that names like, hey, I'm concerned, I've noticed this and this and this, and I'm wondering if you might be thinking of suicide, right? And then like really naming it and not shying away from it and kind of leaning into like, hey, this is a difficult topic. So I guess I'm curious about your perspective. Like, would you use a similar kind of approach with somebody like Peyton or Gunnar or Orly, like looking for a time where you have a moment to yourself or there's not other people around, and then just really naming, hey, I noticed this and this and this. I'm worried about your food, consumption, that kind of thing. Or is that too confrontational? Like, what's your perspective?
No, I think that is a perfect approach. And like in terms of naming it, like, I don't think I would use the word eating disorder. Like you could say disordered eating, or just the way that you phrased it just now, like, hey, I'm really concerned about your food. Like it could be, I'm concerned that you're not getting enough, or, if like purging is a tricky one, probably not one that you want to be as confrontational about. But certainly, like there will be other, if somebody is purging, they're going to be showing other symptoms as well. Food preoccupation, probably also restriction. So kind of naming those things, and taking them away from the group obviously is a good approach. And really, like, for a lot of people, they may have been going about this for months or years and nobody's ever said anything to them. People get really good at hiding these behaviors. And like I said before, like, I think you guys really work in a setting where there is this unusual opportunity that you are with someone day in and day out. You're going to notice things that, with youth, for example, like their parents aren't seeing them all day when they're at school. There's a lot that they can get away with in that time. And so this could really be that golden opportunity for somebody to get help. So if you are that person in their life that really just like sensitively and compassionately can call this out, like, a lot of people would be relieved by that. Yes.
So I've moved more into like the administrative role of like, assessing and screening participants to go out on our trips. And we're definitely seeing people who are self-disclosing, having disordered eating or eating disorders, and it being in a state of management, or there has been treatment. I'm wondering if you have any thoughts on, like, as someone who is trying to think of like this person's success on the trip, also as staff's ability to support this, if you have any tips or like questions to ask to like gauge how prepared everybody is to be able to manage this.
Totally. Yeah. So I'm assuming like you get some information in written form and then you have the opportunity to like speak with that person.
Yeah. Form or like an assessment form of, mainly on the med forms that we have.
Yeah. Okay. So I would want to know like how long the person has been in treatment, and what type of treatment. So like if somebody's been in like just come out of outpatient or inpatient treatment or residential treatment, I would be seriously thinking about like, hey, let's revisit this in 6 months. Whereas like, if they've been in outpatient treatment for a year, they've been, like, another thing I would want to know is like, are they on a meal plan? And if so, like, is that something that you're going to be able to match or support? Are they working with a dietitian? Can the dietitian help to adjust the meal plan for the amount of activity that's going to be on the hike or trip? Like, really like knowing sort of what support they have beforehand and how they can make plans around that, like with their treatment team. And then, like, potentially, like, even if there's an opportunity to liaise with that treatment team and see, like, get some really specific recommendations. What does their doctor think about this? What does their doctor recommend in order for them to have the best success on the trip? And kind of utilizing those resources as well, because like, I can give these sort of general pieces of guidance, but if they have a team that knows them, they'll be able to provide like really individualized recommendations as well.
I like that. Thank you. I think it also is just, I think specifically around the managing and like, are we set up as an organization to support what would help them be successful? I think also helps me think through like staff capacity to support and that sort of.
Absolutely. Because like if somebody's in a stage where they require meal support at every single meal, and you've got like, say, 2 facilitators for a group of, 20 or whatever, like, is it going to be manageable and reasonable to expect one of those people to be dedicated to this one person at every single meal? So those are all things to take into consideration for sure.
Thank you so much.
Mm-hmm.
Jen, I was just going to say, I don't remember if you were at the Sarah Coulter talk that we had in February, but she's the admissions coordinator for Outward Bound Canada. And you might be interested to watch that talk because she talks specifically about doing an intake process with folks who have different mental health things come up and creating like plans for, how to support you in the field. And also, is this the right trip for you? That might be an interesting one for you to watch. I have one more question for you, Jess, but I'm curious if anyone else does first.
I have a question.
Oh, sorry, go.
Thank you. Jess, so I work in wilderness therapy, and historically, people with eating disorders kind of get, routed away from that type of treatment just due to the rigor of it. It's meant to push someone physically, mentally, emotionally, spiritually. I've been really curious, though, about how to go about, from a medical standpoint, how to use wilderness as a tool for people with eating disorders. Because it has so much power. I think most people here can attest to like the power of wilderness and how it can change treatment. So how, from like a medical standpoint, can someone use wilderness in their treatment?
Yeah, I think it's a great question. And like, I sort of think of like, and, obviously everyone here has a lot more expertise on the wilderness side of things than I do, but like there's different groups of benefits. There's like what you're talking about of like, yeah, it's challenging. It will push you to your edge if you're like out surviving for days at a time in these remote areas. But I think there's also a place for like, nature has a gentler side as well that I think can be really healing for somebody with an eating disorder. So like, approaches like forest bathing and, like getting out and meditating in nature, listening to the stream, like being with the trees. I think all of those things are things that can definitely benefit people with eating disorders a lot and don't require that level of like, super strong activity. So maybe it's looking at, places like that aren't so remote, places that are, closer to the city where it's like, you can just sort of be dropped off, be in nature, whether that's in a group setting or like one-on-one with a support person. Because it is like, there is, if somebody does have a severe eating disorder, sneaky exercise is a big thing. So you want to make sure that it's done in a safe and supervised way. But yeah, I think that absolutely those kinds of like gentle exposure to nature can be so, so healing.
That's really good. Thank you. Yeah, like wilderness is often this like rugged and raw experience, and it can be that, but it can also be that. I really liked how you use the word gentle. Like it can also be that. It's so many things. So that's really good. Thank you.
I have a quick question.
Yeah.
I've just been thinking a lot about like supporting people, because like it is weird in a lot of like these settings. You come together and you're like eating in front of a lot of people and eating food that you're not used to. And I'm just wondering if we could talk more about people that like aren't like, that are not eating and then wanting to like go off and eat on their own, or are not comfortable like eating in front of people, or like hiding food in their tent, etc. And I just wonder if you could touch more on that issue.
Yeah, totally. It's, like definitely would be, challenging to manage that in the settings that you guys are working in. And like, again, I think it comes back to this, like what is the capacity of your teams around like, okay, like, is there, if somebody like absolutely cannot eat in front of the group, then can somebody, go off and supervise that? Is that possible, or is that not possible? Can you like have them, work towards it? Like maybe it's okay for one of the leaders to go for, the first day and get that person used to it. And then you agree that like, okay, but then the next time, once you're used to this new menu, like, okay, you're going to be eating with the group. And like if it's not possible to mitigate those behaviors, then maybe that's where you're kind of looking at like, okay, like, is this the right setting for you? Or, can we support this? Or does this have to be like, okay, maybe we circle back around and try this again next year, or things like that. In terms of like hiding foods, is it something that you like would discover or like be aware of in the setting that you're?
Yeah, I was thinking more so, just like someone who was really uncomfortable eating in front of people, and then like noticing that like there's like wrappers near their tent, which isn't like very safe, or like just kind of how to like
exactly. It's not safe in that setting.
Yeah, and you're happy because you want them to be like eating, but then you want to address that concern and like just kind of like how you go about that.
100%. Yeah. And like, I would discourage the secretive eating where possible, because, like, even though you want them to be eating, it's like, that's when you're likely to see binge eating, which then results in rebound guilt. They're not going to feel good about it afterwards. Hoarding food is like, it's not something that the person is going to feel good about. So like, I think like honestly, the bear safe thing is a great cop out. You can just be like, hey, I noticed this. I'm concerned that, a bear is going to come and maul you in the middle of the night, right? Like it's an easy way to address the behavior without having to address the behavior. I mean, like you can address it directly and just kind of name like, hey, I saw this. But I think in this case, it's like you have an easy out there. So might as well take it.
We have about 6 more minutes left until 7. And I do like to honor the fact that everyone kind of signed on and expected to be here until 7. So I will invite us to have a formal end at 7. And if anyone does want to stay a few minutes longer and chat with Jess after, ask more questions, then that's completely fine as well. But I do like to, we've all been in meetings that, we never know when they're going to end. So was there anyone else who had a couple of questions? Or else I have. Sean, you started to ask one earlier. Did you want to voice that?
Well, my question has kind of been formed as my main question has kind of been formed as a comment now, because it's very similar to Brent's. But so when long before I got married and had 6 children, I dated a few people who had disordered eating and eating disorders, and I guess my comment is just, I wish I had known all this stuff then. I didn't. I wish I had handled it differently. And and so thank you so much for what you're doing. It's very, very important. And that was an awesome presentation. And I have one very unsophisticated question, which is, you were mentioning electrolytes, supplement electrolytes. Are you talking about just like a powder that you can throw in your water or whatever?
Yeah. You can get like Pedialyte and Hydrolyte are good ones. You can get them at any Shoppers or, any drugstore, grocery store.
Sometimes in medical woofer classes that I've taken, we've talked about like eating bananas also has electrolytes in it if you don't happen to have a pack with you or something like that.
Definitely get that potassium.
Mm-hmm. Heidi, I see your question. I'll hold mine.
Yeah, I guess less of a question, just a thought to add to the conversation about electrolytes. As Jess was talking about it, I was just thinking about logistically as well, something that might be maybe less top of mind, but also important when we had the conversation about whether to evacuate someone, was like, if electrolytes was a challenge or a problem, taking into consideration how long the trip you is on, and like how much access you do have to electrolytes, and how if you're using that all for one person, that could potentially impact the rest of the group, depending on like the situation. So I just wanted to.
It's a great point to raise, because like when you have somebody who's, who is depleted and is needing to manage that, like I've seen people who are on electrolytes at every meal. So that's a lot of electrolyte packets to bring with you. And again, like you don't want to be running out of things that you need for other participants. So yeah, I think that's a great point.
Jess, I was wondering about, so looking at the scenarios that you have up there, and I've been on, I think, trips with all of these people, but I think I've had a lot of youth who showed up like Orly. And I was wondering if you had any thoughts on, so if I were sitting with Orly, and I remember sitting with this one young woman who was quite a bit like Orly, and her restriction around like what was good food and bad food is she wanted to eat a lot of very plain food. She wanted bread with nothing on it. She wanted noodles with maybe some butter, and maybe some salt, but like none of the, chili, none of the protein, none of the vegetables, right? She was very, very focused on plain and simple foods. And so I guess when you're looking at someone like Orly or someone like that youth I was describing, I was just wondering about like, if you're trying to create a safety and support plan with them and figure out like, okay, how can I best get you to stay in the field? How can I set you up for success if that's possible, right? I think, yeah, there's a time and a place where it might not be possible, but what are your thoughts on the idea of like, should you go along with some of the restrictions in the name of trying to keep them on the trip and make it possible for them? Or is that reinforcing, right? Is it something like, okay, yes, I'll scoop out some noodles for you before I put the sauce in and put them aside for you. Or is it like, you have to eat a little bit of sauce? And I just remember this trip where I was really struggling with that. So I'm just curious what your thoughts are. Is that reinforcing if I put the noodles aside, or is that helpful to this person?
Yeah. Okay. So I think there's two angles that you would come at this with. Like, one is I think from that perspective, like I think depending on the length of the trip, like, if someone's out there for a week, like if they're getting enough food, I would not be like overly concerned. And that is how, like, in eating disorder treatment, you start with the foods that they're comfortable eating, and then very, very slowly build in challenge foods. The other consideration that I would be paying attention to in that scenario is the other group members. So like, are you seeing that, all of a sudden nobody else wants sauce on their pasta and things like that? And like, if that's not happening, I wouldn't be overly concerned. I would definitely be like, if this youth's parents are not aware, I would be telling them, I would be letting the youth know and disclosing that for their safety, because that's somebody who is going to need some support. But yeah, if it's not significantly impacting the group, that's not something I would necessarily push on, because it is like, it's something that they would have to gradually work up to in treatment anyways.
Yeah. Thanks so much for addressing that. That scenario has been on my mind for quite a while, actually. Any other quick thoughts or questions we want to voice for Jess before we have a formal wrap? Jess, did you want to drop your... Oh, sorry. Go ahead, and then Jess,
I can ask it now, or I can ask it in a minute, whatever would be better.
Jess, do you want to drop your email as well, just in case anyone does think of a question later? I think you said you might offer that as a resource.
Where is the chat here?
And Joe, what's on your mind?
Yeah, I am just thinking about how, like, at the beginning of trips, especially long trips, we do some like nutrition framing to students. And I'm curious about like how to frame eating in the field, like taking into account like change in strenuous exercise and then change in routine. Like, so much is shifting. And I think it's not a good place to like drastically change eating behaviors in some ways. So I'm curious like how you would frame things, or anything you would offer for that.
I'm not sure totally. So like, how to talk to people about eating more in the field? Is that the question? Or like,
yeah, I think that's part of it. Like, I'll often teach a nutrition class of like, here's how you here's what all of the foods we bring are, and like identifying them and like how to use them, and then like talk like briefly, or like depends on who I'm working with, but just like give a little bit of context about like what our body needs to run and function in the field, and just like providing context for all of the students. So like thinking about that, and then also thinking about disordered eating and like how that can like show up in the field sometimes. Like, is there any way that you would like frame that or like add something into that?
I see. Got it. Yeah, I think keeping it like pretty general is fine. I when I'm working with youth with disordered eating, I always just like fully avoid the word calories because it's just a big trigger word. And so like I might use the word energy. Like avoidance of numbers is a big one. Like anything that they can kind of latch onto and fixate about is definitely good to like steer clear of. So just being like a bit more general in terms of that, and like, yeah, just framing it as like, hey, like your body's going to be working harder. It needs more fuel, and really just looking at it that way in like in terms of like fuel and energy, because that's what our bodies are. They're like, they require a certain amount of input, to be able to like function and do all the, oh, and also like, that it's not just around like fueling to be able to do the activity. Like our bodies just like do a lot of other things too. So like if you're outdoors, like you're also keeping warm. You're also, doing all the basic things that you normally do, like digesting, and like, so there's a lot of systems in the body that have to function properly, and being in an extreme situation puts added demands on that. So I think that's probably how I would frame it. And obviously, like you have all of your layers of expertise as well around certain conditions in the field as well. So kind of blending that with that as well.
Cool. Thank you. Yeah, I like the idea of decentering numbers and like not talking about calories.
I also like what you were saying earlier, Jess, about the idea of looking at the stages of change, right? Like, is this person open and receptive and interested in the information, or are they more restricted? And if they are more restricted, maybe we phrase the information more as questions or as choices, right? Like, absolutely. Here's what's needed in the field, and your choice is maybe to we can help you find a different trip if that's not going to work for you, right? And phrasing it really compassionately, something like that.
Absolutely.
I want to provide a formal wrap because it is a little past 7. And Jess, I just appreciate you being here so much. It's nice to see how much your practice has grown as well since we did our grad studies together. And this information was just so wonderfully kind of curated and formatted, and we can benefit from your expertise in kind of digestible ways. I really like the idea that you provided as well about providing some after meal support that may or may not seem like after meal support, right? It might be as simple as like just making sure there's some kind of group activity or discussion or a music circle or something going on after supper, and providing that little bit of like natural distraction and connection. But yeah, so much more that I'm sure we'll have a chance to talk about, and hopefully we can integrate this more in the course too. So thank you so much for being here.
I really wanted to thank everybody as well. You guys were so engaged and everybody had such great questions. So thank you for showing up and being here tonight.
Awesome. I did see a question in the chat about whether the PowerPoint slides might be made available. So we did record this, and we'll put the recording up, but are you also planning to send out the slides?
I'm certainly happy to send out the slides.
Great. Awesome. Well, thank you so much. So yeah, let's all thank Jess, and I'm happy to stick around for a few more minutes if folks do want to ask more questions, but feel free to leave and enjoy the rest of your evening, everyone. Thank you so much for being here.
Thanks, y'all.
Bryn's still here. Is that intentional?
Hey, I just have a question about like the 3 and 3 rule, if you guys have like a sec to talk about it. I've heard this like quite a bit, the idea of like, if you identify that somebody's struggling with disordered eating and implementing like a lot of calories to like help them like physically like right away. But I've always kind of not fully understood that, because I thought that it would cause people like, because it's like a mental health thing, that it would cause them to start to have a really like resentment towards that. And like, I understand that the physical health is important, but I'm just wondering if you could, if you have the time to like explain a little bit more why that's.
I don't know. I probably should have gone a bit more into depth with that, because that's like once somebody's getting going, that is like the ideal scenario. And like, you know, if somebody's going to be going into treatment, they're going to be getting a meal plan. They're going to be working with a dietitian. They're going to have support on like how to build up to that. Like, I would start out with like what the person is able to agree to that meets the demands of like what they need to be able to continue on the trip. Like I would be like pushing it to a point where they're like completely panicking and freaking out.
Yeah, for sure. I've just had some personal experiences where people that I knew were experiencing that, like it was pushed on very, very early on. And so I was just kind of wondering where that like idea kind of came from, for it to be like doubling us normal when you're already so below average.
Yeah. And it really like, it depends where you go to treatment. Like most places are pretty good about like slowly working people up to it. But I think there still are some places out there that are kind of like throwing people in the deep end. And definitely like, you know, years ago, that was kind of the standard. Kind of like, I don't know, there's been a lot of back and forth around like whether syndrome is a concern, which is a whole other thing. And so yeah, there's a lot of factors to consider there, but yeah, definitely don't feel like you need to like, you know, if somebody's eating nothing, to like go from that to them all of a sudden eating like 3 giant meals and snacks.
Cool. Okay. Yeah. Thank you for your take on that. That's helpful.
I imagine some of that is done like not by getting them to sit down and eat a bunch of steak and potatoes, but like through nutritional supplements or shakes or whatever.
Absolutely.
Right.
Yeah,
that might be a lot.
Yeah, totally. Especially when somebody's experiencing premature fullness.
Yeah, for sure. What is normally used I know there's all different treatment options, but like in a more extreme setting, like in inpatient setting, like what are they actually feeding folks?
For supplementation, usually Boost or Ensure. And then, you know, in really severe cases, if they won't take any food orally, then you would use a nasogastric tube.
Right.
That's very unpleasant for people. So it's a last resort.
Yeah, for sure. Yeah. And I imagine the goal in that case would be you said earlier that one of the kind of side effects of being nutritionally deficient or depleted is the cognitive effects, right? So you're trying to, in one case, just like, you know, nourish their brain enough so maybe they're in a better place to make decisions.
That's definitely part of it. And the other is like to prevent loss of life. Because if somebody is, you know, in a bad spot, then they'd be at super high risk. So
we probably wouldn't see someone with that severe of a case in the field, but we might see someone in recovery from that kind of case in the field.
Somebody who had experienced that, absolutely.
Yeah.
Interesting. Okay, thank you so much. Thank you for your time and day. It was nice to see you again.
Nice to see you, Bryn.
Lovely. Have a good night, you guys. Thanks so much.
Good night. Jess, I feel like I could just sit here and ask you questions.
Hey, if there's more that I can speak to, I'm happy to.
I'm sure there is. I have 2 pages of densely written notes on the things that you talked about, and I had already gone through your presentation, so that's saying something. I think a lot of what you talked about is it either kind of you directly named things that we already talked about, like the safety support plan. You also talked about like starting with the emotional support and then moving to the practical support. And I think you call that left brain, right brain. We call that lizard brain, wizard brain, but it's the same thing. But I just love seeing how what you're talking about just maps on pretty well to what you talked about before. So I think it would be a good thing to include.
Oh, that's awesome.
Yeah. Do you suggest talking to people about like intuitive eating? Like when would you introduce to people, or how would you introduce to people the principles of intuitive eating? Like I know you might do it in a certain way therapeutically as a clinician, but I wonder if I were sitting with someone in the field who was maybe like, yeah, I'm open to talking about like my eating and maybe making it healthier, and I have struggled with it. You know, would I sit there and be like, well, there's this thing called intuitive eating, you know, have you heard about it? Or like, here's a thing on my phone or something. You know, how would you introduce it?
I would just like pick, like, because the whole approach could be like a little bit overwhelming to like all at once. And like, especially if they're early on in the process, like you're really just going to focus on like probably 1 through 3. So like, I think just like having an understanding of the model yourself, maybe reading the book and like checking out the website so that you know what it's talking about. I mean, they like, Evelyn Tribbley's been on like every podcast known to man. So like there's lots of accessible ways to get the information. And then, you know, just really kind of like dropping in little bits and pieces of it. I never teach it in a systematic way in my therapeutic work, because all of the people that I worked with in that setting were also seeing the dietitian, and that was kind of her, the main thing that she was working on. And so like I was certainly familiar with it, so that if people had questions, then like I could clarify, but it wasn't like the bulk of what I was doing. And then if they're curious to know more and they're asking a bunch of questions, then maybe sort of redirect them to
Do you know if it's, is it something like, is it a registered thing? Like, I'm just wondering if I can cite it. Can I cite it? Can I say what the different steps are? Like, can I put it in the manual?
Totally. Yeah, absolutely. I think you could cite the book, you could cite the website, like for sure.
Yeah, for sure. I'm just wondering if I can like name the steps or like teach, not that I'm at the stage where I would, but you know, could I look at incorporating like teaching the steps or talking about the steps as part of this program? Or is it like,
like they're pretty like, I think they want this to be widespread. I would say that you'd be pretty safe to do that.
Yeah, I mean, I see it kind of cited everywhere, and like you went through and named the steps, and it didn't seem like a big deal. So.
I don't think that would be a problem.
Yeah, okay, that's something I'll look at.
Yeah, I mean,
maybe in the fall.
Reference the book when you do it.
Oh, for sure. Yeah, for sure. And I know you mentioned the author, and I do all that. Yeah. I'm pretty good at doing all my citations. I'm pretty good at knowing where my information comes from. I'm not good at putting the citations in APA format, but that's what I do.
Yeah, totally.
Yeah.
Yeah.
Sean, anything else you want to add? Sorry.
No, okay.
Yeah, I actually did have a question around intuitive eating, and that's because I know one of the things you said is to not have rules around eating. And so for me, like I eat a plant-based diet. And so there are like some self-imposed rules. Yeah, there are some self-imposed rules around my diet. And I'm just wondering, like, how is that something you would push against in recovery?
No, certainly not. Well, okay, it's tricky in recovery. So like it depends on a lot of things. It depends on what treatment program is doing it. Some are like hard line, absolutely not. We don't support that. And part of that can either be because the treatment program's like not set up to support that. So like some of them just like don't have the funding to be able to provide 3 separate meals for different people. And for some of them, it's more of like a moral decision of like, this is a feature of eating disorders. And so we just see it as a symptom of that in all cases, or we don't want to trigger other people in the group or things like that. For me, I would be looking at like, how long has this person been plant-based? Is this did this start around the same time as they started trying to lose weight? That's a big red flag. But, you know, if this is an ethical thing for them and they've been plant-based since, 10 years ago or their entire life, like, then I would be more likely to try to find ways of supporting that.
Right. So it sounds to me like you're saying that part of it is the intention behind the rules that you have for your diet.
I would be looking at the motivation for it.
Okay.
Yeah, for sure. And like, with certain things, it's tricky. Like, like some people will say like, oh, I have sensitivities to like all these different foods, and it's just a way of avoiding eating. So, just kind of like being curious, asking a lot of questions, trying to kind of dig into that a little bit more and see if you can kind of suss out where is this actually coming from.
Yeah, because
Awesome.
it can
Thank
show
you.
up the other way too, right? There's people who only eat an all meat diet. I mean, it's rare. It's certainly more rare than veganism, but that happens
totally.
as well. Yeah.
Yeah, absolutely.
Yeah, that's a nice lens on it, though, is looking at, okay, what's the motivation for it? And also, did it pop up at around the same time eating disorder started?
Yeah.
I didn't have time to get into orthorexia today, but that's like a big one in that, like, and I imagine like it would have been good because I imagine that would come up potentially in these wilderness groups, because you get like these health conscious people that are, and it's like, so.
What's orthorexia?
Like a wellness focused eating disorder. So it's not so much about like weight and appearance. It's more about like the purity of food and like really like being like terrified of anything that's not organic or things like that, like being really rigid and inflexible around food rules based on wellness.
Yeah. Interesting. Yeah. Now, Jess, this was a slice. Thank you so much. This was absolutely wonderful.
No problem at all. Thanks for inviting me. It was fun.
Yeah, good. Yeah. Well, I hope we get to reconnect. Okay. Good night, everyone. Thank you so much.
Hey, guys.